to welcome Dr. Ziyad Hijazi, who I've known for many, many years. When I was a fellow and before, Dr. Hijazi has run the largest pediatric interventional cardiology symposium, a U.S. and international interventionalist of great renown who travels extensively, who helps people all over the world learn and assimilate new techniques. Ziyad, welcome.
Thank you so much, Eric. Thank you. It's a pleasure to be here.
So we're at the Toronto course for congenital and structural heart disease, and really Ziyad is ideally positioned to talk about the future of intervention in structural and congenital heart disease because he is so in touch with the latest and greatest happenings. Ziyad, where do you see us? Let's take a few areas and talk about where we think the future is going to be 5 years, 10 years down the line. Let's start out with cath labs in general.
Yeah, so thank you for having me first. Cath labs, as you have witnessed over the last few years now, we have the best machines, the flat panel technology, the 3D rotational angiography. This will continue to improve so that the dose radiation that we give to our patients will be less and less, as well as the amount of contrast we give for each injection will be less. So I think the advancement will be significant in that the image quality, the image acquisition, as well as the reconstruction time for these angiograms will be much less. So I think that's a big area. The other area in the field that I think over the next 5 to 10 years is bioresorbable stent technology, scaffolds. As you know, when you take a child and you put a metal stent, by default you commit them for repeat interventions. So if we have the ideal bioresorbable scaffold, imagine you do one intervention and hopefully that will be the end of that. So right now, our group, myself and Damien Kenny and other groups, Martin Bach and Dan Levy, they are all working on different alloys and metals to test in the animal lab and hopefully soon in the human lab. So we have done an animal study at Rush University testing one of the bioresorbable scaffolds with PLLAA, and so far the results are encouraging, and we are talking with the FDA hoping that they will allow us a limited early feasibility study in humans, in children soon. So I see the field over the next 5 years to go to be very hot in the field of bioresorbable stent technology. The last field that I think wide open is valves. Valve technology. Right now we have good valves, but as you know, they don't meet the demands of all patients. Number one, because of their design. Number two, because of the size of the catheter that we need to deploy these valves. So as you know, we're working on the venous B valve. We're trying to bring it to North America, to the US and Canada, hopefully soon, because the early results outside North America has been very encouraging.
You've had a profound impact on the education of new physicians and the continuing education of physicians. Can you make some comments on what you feel are the ideal approaches to do this, what we should be doing to both to improve what our colleagues are doing and to educate the next generation?
Yeah, this is such an important question, and as you know, I strongly believe in education and in disseminating the knowledge, and to make sure that the next generation interventional cardiologists will not fall into the traps and the pitfalls that we encountered going through it. So first of all, proctorship is extremely important. So do not use a device or something without being proctored by an expert properly on that device. Second, attending national as well as international meetings. Over the last 2 days here in Toronto, I've seen the young cardiologists here learning intimate boutique course, limited number, and that actually, in my opinion, I go to another course like this for adult intervention. It's about 50 people. That's the course I, as a faculty, learn the most. So I think courses like this are extremely important, as well as choose a mentor or a colleague that you call often when you need some help for tips. When you have a tough case, just discuss it with that person, ask them what would you do, how is your approach, and then go from there. So I think education is a key and a message and a responsibility for all of us to disseminate. Be generous with your time and discuss things with your colleagues so that they will have a great outcome with their patients.
I mean, I think you couldn't have said it better, because I know that I have a winner as a trainee when the questions don't stop.
Yeah.
And when they finish the fellowship, the questions don't stop. And you know what? Those are the people who are the greatest, become the greatest, most insightful interventional people.
I agree.
I want to take a quick tour around the rest of the heart in terms of interventions we're doing. Septal defect closure, things that are new, things that are upcoming.
So I think that's a great, no question that devices we have now are great devices, we manage with them, but you know what, you're leaving a big metal in the heart. We don't know really the long-term sequelae from that. I think, again, bioresorbable technology for septal occluders has to happen. We have to implant something that after a couple of years will disappear, so that if you need to go to the left side, you don't have to struggle at all. And you know that in majority of patients, you will need to go to the left side at one point. So that's where I see the field heading, bioresorbable devices for the septal defects.
I'm going to ask you a last question. I'm going to let you go. Are we going to be able to resolve the VSD issue? Is there technology for VSD for small children that are going to allow us to make progress without that feared heart block and the issues, of putting in a permanent device in young people?
Eric, I am an optimistic person. I strongly believe one day we will tackle and resolve all these issues. So development again is ongoing for the perimembranous VSD, because muscular VSD, I think the current devices, they do a pretty good job, although you leave a metal there. But the Achilles heel of perimembranous VSD is the heart block, and there's no question I don't know whether it's within the next 5 years, 10 years, but eventually we will tackle that problem, and you will be able to close a large perimembranous VSD without putting the child on, on the heart-lung machine. So this is exciting field.
So with that, I think we're going to close. Ziyad has been a mentor of mine for many years and has always been so gracious to me. It's such a pleasure to finally welcome him to Toronto and to our meeting. It was a real pleasure having you, and I just want to thank you so much.
Thank you so much, and congratulations on this outstanding boutique course that really not just the attendees learn, but the faculty, because we sit there the whole time listening to everybody's talks. The other big meetings, you do your talk and then you just leave, go to the faculty lounge or something. But this course, honestly, congratulations to you, Lee and Mark. Thank you so much.
Thank you.